we have a 63-year-old female currently in the hospital, admitted for mild abdominal pain, nausea, and emesis. She was home recovering from having an MI when she started having abdominal pain, and so she presented to the emergency department, where CT angiography showed an occlusion at the origin of her SMA. Well, gosh, doesn't that sound like an embolus? The physicians diagnosed acute mesenteric ischemia, but decided that she was stable, and so they admitted her to the hospital. They made her MPO, started IV antibiotics, and anticoagulation in the form of IV heparin GTT. 24 hours later, she's still having abdominal pain and sounds like it might be a bit worse. Sounds like the current course of action isn't quite doing enough to solve her problem, and we need to do something else. But she is still stable at this point. With mild fever, mild tachycardia, her blood pressure is within normal limits, and her white blood cell count is normal. She does not have signs of peritonitis, but she is a bit tender. They ask, what is the next best step in management for this patient? Before jumping into trying to answer this management question, let's pull in some things we remember from our previous sketch. In our last sketch, we went over the clinical presentation and workup of acute mesenteric and colonic ischemia. That sketch leaves off after we've gotten our labs and imaging, most likely CT angiography. Once you get that CT, we have to have the etiology nailed down because that is going to determine how it is treated. Remember that there are a few categories to be thinking about here, which can be boiled down to occlusive and non-occlusive disease. The most common occlusive cause is embolic, with the emboli usually arising from the heart in a patient with an arrhythmia, recent MI, aneurysm, or diseased valve. That includes endocarditis, friends. The embolus most commonly becomes lodged in the superior mesenteric artery, causing ischemia to the small intestines or proximal colon, at which point it's called acute embolic mesenteric ischemia. In our patient, the CT angiography demonstrates an occlusion at the origin of the SMA, and she recently had an MI. Embolic disease definitely fits this picture and is the most common cause. Sounds like we have our etiology, but let's continue our review. Occlusive disease can also be caused by thrombus formation in the mesenteric arterial system. Thrombotic ischemia usually occurs in the setting of atherosclerotic disease or a hypercoagulable state, such as polycythemia. Though there are other causes of thrombosis to consider, such as infection, aneurysm, trauma, or surgery. These patients most commonly have a history of chronic mesenteric ischemia due to atherosclerosis throughout their mesenteric arterial tree. Unfortunately, one very unlucky day, a plaque ruptures just like an MI, but of the intestines. The last important occlusive etiology is mesenteric vein thrombosis, which is associated with hypercoagulable states, malignancy, or prior abdominal surgery. Yep, that's a cancer crab. All right, that brings us to non-occlusive etiologies. In critically ill hospitalized patients with prolonged hypotension, excessive vasoconstriction or spasm of the SMA leads to ischemia of the small intestines and proximal colon. And on top of that, add meds. Many agents that are used for inotropic and blood pressure support also cause splanchnic vasoconstriction, thus reducing intestinal perfusion. And in its own category is colonic ischemia. Yep, mesenteric ischemia generally refers to small intestinal or proximal colon involvement. Colonic ischemia is a whole nother beast. The colon's collateral circulation is crappy, especially at the watershed zones at the splenic flexure and rectosigmoid junction. Colonic ischemia can arise due to any of the mesenteric causes we just described, but the vast majority of cases are non-occlusive due to hypoperfusion. In fact, non-occlusive colonic ischemia is the most frequent form of intestinal ischemia, period. The prototypical patient with colonic ischemia is elderly, and either is undergoing a procedure that causes a transient reduction in blood flow to the colon, such as aortic surgery, cardiopulmonary bypass, or hemodialysis, or has had a recent MI or episode of shock, or this patient is on a drug that reduces colonic blood flow. Examples include illicit drugs like cocaine, and even some constipation-inducing drugs. All right, Check out the last sketch for more on the presentation and workup of mesenteric and colonic ischemia. On to the plan. If you have a high suspicion for mesenteric ischemia, it's time to make your patient MPO and place an NG tube to facilitate GI decompression. IV fluids are also started to promote visceral perfusion. Hey, that sounds familiar. That's exactly what they did in our case study. Pain control is important here as well, usually accomplished with IV opioids. You can see our recurring sketchy symbol for mu opioid receptors antagonists. The Mutopia Resort and Spa. Let the pain melt away. Most patients with acute mesenteric or colonic ischemia will also receive broad-spectrum antibiotics, in case they've already perforated. Also to combat the translocation of bacteria through the necrosing intestinal wall. These bacteria can enter either the peritoneal or pelvic cavity, or even the bloodstream. These patients are at a very high risk of severe septic shock and death. Antibiotics should include gram-positive, gram-negative, and/or pseudomonal coverage. Anticoagulation therapy is also started in patients with suspected mesenteric ischemia due to embolism or thrombosis. The occlusive causes, that is. Hence the gunky pipe here in need of some declogging. Anticoagulation is not indicated in the setting of non-occlusive ischemia. Remember, colonic ischemia is usually non-occlusive. Low flow. Surgery is often indicated in these patients. However, unless a patient is going immediately to surgery, a reversible anticoagulation is usually started. This is most commonly heparin in the form of an IV drip. But if a patient has already perforated, surgery must happen fast, and so anticoagulation is not started to decrease the risk of bleeding intraoperatively. Also, hold off on anticoagulation if there are signs of active bleeding. Remember, both antibiotics and anticoagulation were started in our case too. Alright, the next steps in management depend on the suspected etiology and severity of ischemia. Let's start with all the mesenteric causes of ischemia before we talk about the colon. Remember, these pathologies include embolus to a mesenteric artery, thrombotic mesenteric arterial occlusion, mesenteric venous thrombosis, or non-occlusive mesenteric artery constriction or spasm. Well, if the patient is stable and symptoms of ischemia were transient or minor, and there are absolutely no signs of advanced ischemia on exam, labs, and imaging, you can actually just observe how well they do on an anticoagulation and fluids, just like our patient. The key here is to support cardiac output and get blood flow back to those intestines. That includes removing any factors contributing to reduced perfusion, such as treating sepsis or heart failure, discontinuing vasoconstrictive medications, and providing hemodynamic support. Alright, what do you do if your patient has symptoms of ongoing ischemia and you don't think watchful waiting is going to cut it? Well, the choice here is whether to pursue an endovascular approach or go straight to surgical exploration. That kind of seems like the decision we have to make for our patient, doesn't it? What do you think? Do we need to go to the operating room right away? In general, patients who are, number 1, stable, and number 2, have no clinical signs of advanced ischemia, we're talking peritonitis on exam or radiographic features like free intraperitoneal air or air in the intestinal wall. These patients are candidates for an endovascular procedure. And so is our patient. If an arterial pathology is suspected, start with mesenteric arteriography, also known as angiography, which involves squirting some dye in the affected arteries to get a better idea of what's going on. The next step in the therapy depends on what's blocking the flow. Emboli and thrombi are removed by either embolectomy, thrombectomy, or catheter-directed thrombolysis. Then top it off with some angioplasty and/or stenting. Yep, just like when you're blocking a coronary artery. Arteriography is usually repeated a few hours later to make sure the clot was removed. If non-occlusive ischemia is suspected, which shows up as diffuse vasospasm and decreased perfusion on angiography, you have the option of using catheter-directed vasodilators right at the site of constriction. Alright, back to that stable observer. Mesenteric venous thrombosis is a slightly different story. Most patients can be safely monitored on anticoagulation while the clot resolves. Serial clinical exams, labs, and imaging are attained, with a low threshold for surgery if there are any signs of transmural ischemia, infarction, perforation, or bowel obstruction. Catheter directed thrombolysis can be used as an adjunct to anticoagulation therapy at specialized centers. We've made this piñata a crab because this is frequently seen in cancer patients, hence our cancer crab. Just stick that wire in that vein and see what happens. Hopefully, an almond joy. Let's change things up in our case from the beginning of this sketch. Let's say the same patient is admitted, but 12 hours later, she is complaining of worsening and now severe pain. She has a fever of 101.6 Fahrenheit. WBC is 1800. Her abdomen is stiff and hard and severely tender, with rebound tenderness. A much different picture than the one we had earlier. Guys, this sounds really bad. Sounds like she is no longer stable and has perforated. Well, no matter the etiology, exploratory laparotomy and bowel resection is indicated if 1. Conservative strategies fail, or 2. If your patient becomes hemodynamically unstable, or 3. Has signs of advanced ischemia. We're talking peritonitis on exam or radiographic features of advanced ischemia like perforation or pneumatosis intestinalis. It's surgery time! Die, skull! Die! Sorry, I had a traumatic childhood. Remember, when there's peritonitis or perforation suspected, these patients need surgery as fast as possible, and so laparoscopic surgery is not the correct answer. Though, while on your surgery rotation, you may see expert surgeons begin these procedures laparoscopically. For exams, perforation means a large abdominal exploration. They may try to trick you by giving you the option of laparoscopic surgery. Laparoscopic surgery may be an appropriate move if the diagnosis of ischemia is questionable. All right, once you're in there, time to explore. Perforated areas, as well as clearly non-viable sections of bowel, are stapled off and resected. What the? Torn wrapper? Nope. Oh, come on! Black licorice? Ugh! To distinguish between viable and non-viable bowel, there are a few features to look out for. Inspect the appearance, looking at the color and amount of distension, and if there's peristalsis. Dark, distended, and paralyzed regions likely have full thickness ischemia and will need to be resected. In addition, check for peristalsis and arterial pulsations. We've got live tissue here, people. Or if you notice any bleeding from cut surfaces, you might just have some viable bowel in your hands. Ooh, yummy, fruit filling. The key here is to leave bowel of questionable viability alone, because a revascularization procedure may be able to restore perfusion to ischemic bowel. In cases of occlusive arterial disease, next thing to do after removing any dead bowel is head over to the lesion-causing occlusion. Common procedures used to relieve mesenteric artery occlusion and restore perfusion include open embolectomy, thrombectomy, endarterectomy, mesenteric bypass, stenting, or some kind of combo of these. And why the fluorescent green shirt, you ask? After the procedure, the bowel is reassessed for areas of irreversible ischemia, sometimes with the help of fluorescein or indocyanine green dye injection into the mesenteric arterial tree. Just follow that dye. Again, non-viable areas are resected. And time to close up shop. Well, sort of. Turns out that in many cases, especially those with extensive ischemia or necrotic bowel, the abdominal wall will be left open. Whenever there is a bowel of questionable viability left over after surgery, a planned second look or take-back operation should be planned 24 to 48 hours later when the bowel will have declared itself. At that point, you can reassess the bowel, which hopefully has reperfused. If not, it will be resected. All right, let's finish up here with colonic ischemia, aka ischemic colitis. Remember, this is the one that typically involves the watershed zones at the splenic flexure and rectosigmoid junction. Colonic ischemia can arise due to any of the mesenteric causes we just described, such as embolic occlusion or thrombosis. But the vast majority of cases are non occlusive due to hypoperfusion. So we'll focus on that etiology for the remainder of the sketch. Remember from our last sketch that the prototypical patient is an elderly dude undergoing a procedure that causes a transient reduction in blood flow, or has had a recent MI or shock episode, or is on constipating drugs. He has nausea, left sided pain over the watershed areas, maybe bloody stool, and CT shows maybe some edematous bowel wall or dilated colon. Remember, there are numerous pathologies that cause abdominal pain and bloody stool, especially in an old dude. Think of inflammatory bowel disease or diverticular disease. Know what I mean? When a definitive diagnosis of colonic ischemia is necessary, the gold standard for confirmation of colonic ischemia is lower endoscopy, usually colonoscopy. Minimal insufflation is used in order to prevent distension and perforation of ischemic colon. It's all about finesse. Don't want to pop their pooper. Biopsies of suspect areas can be taken during the colonoscopy as well. In the acute setting, signs of colonic ischemia include regions of edematous friable mucosa. Look for erythema and interspersed pale areas. Those pale areas are ischemic ulcers. If the ischemia is really severe, expect to see cyanotic mucosa, scattered hemorrhagic erosions, or linear ulcerations. If full thickness irreversible ischemia is seen, it's time to head to the OR for a laparotomy and abdominal exploration. If only mucosal ischemia is present, supportive care is usually continued. That means bowel rest, IV fluids, and broad spectrum antibiotics, which are usually reserved for patients with signs of ulceration on endoscopy. And of course, just like in mesenteric disease, if there are any signs of transmural ischemia, necrosis, or perforation, either on exam, on labs, or on imaging, it's laparotomy time. A word about colonic resection. If the remaining ileum and colon cannot be immediately reanastomosed, which is often the case in severely contaminated fields, or if there is not enough length, the patient will probably end up with at least one ostomy. Right-sided colon resection is usually followed with an ileostomy and a transverse colon mucus fistula. That's two stomas, friends. One at the terminal end of the ileum, and one for the proximal end of the remaining colon, both open to the outside world. For left-sided colon resection, a stoma is placed for the remaining colon, while the distal colon is either open to the outside world as a mucus fistula, again, that's two stomas, or the distal segment of colon is stapled shut and left inside the abdomen as a closed pouch. That's called a Hartmann's procedure, and it's symbolized here with the stoma poking out above a stump, just like the closed-off stump of the remaining colon left inside the patient as they recover. As for ostomy reversal, it's usually delayed by 4 to 6 months, and many patients will never have their ostomies reversed due to comorbid conditions. So let's do a quick summary of everything we've talked about. First, we need to determine the etiology. Remember from our last sketch that for mesenteric ischemia, these are either occlusive etiologies made up of embolic, thrombotic, or venous thrombosis, and non-occlusive etiologies from prolonged hypotension, excessive vasoconstriction, or spasm of arteries. And for colonic ischemia, there's all the same causes as for mesenteric, but the most common is non-occlusive due to hypoperfusion in our two watershed areas. After determining the etiology, one of the first steps is to decide, is the patient stable or not stable? All patients will be made NPO, have an NG tube placed, and IV fluids started, whether stable or unstable, and many will get antibiotics and anticoagulation. If the patient is unstable or demonstrating peritonitis, etc., then the management is simple. The patient goes to surgery where the appearance of the bowel can be observed for viability and the necrotic section is resected. and then the revascularization performed. If the patient is stable, they can be observed, or they can have endovascular procedures to try to open the occlusion, such as embolectomy, thrombectomy, catheter-directed thrombolysis, catheter-directed vasodilation, balloon angioplasty, stenting, or any combination of these deemed appropriate. And finally, for colonic ischemia. Colonoscopy is gold standard for determining the level of ischemia. Mild, where the patient will be made NPO and get IV fluids, or moderate, where the patient also gets antibiotics, or severe, where the patient gets taken to surgery for colonic resection and probably an ostomy, or maybe even two. Well, there you have it. Acute mesenteric ischemia and colonic ischemia are diagnoses in the back of every surgeon's mind all the time. This disease process is exactly why each and every single patient that the surgical team sees examined with a thorough abdominal exam on each and every encounter, despite the seemingly complete separation of their presenting issue and the surgeon's area of expertise. Ah, the abdomen. What a dense forest indeed. To see the trees, the forest, I mean. The forest for the trees? And if a tree falls and no one's there, yeah.